I mean, last week we left off with the concept of proprioception and how it actually manifests itself in training and how very important it is. So a lot of the coaches and I decided we'd give a quick talk on proprioception. So we've already touched upon it somewhat with microstretching when we talk about the concept of stability, balance, and control as to how you place your body in a proper position when you're stretching, in order to eliminate any muscle contractions, as we said, but more importantly, to be able to deal with intensity or to modulate or moderate the intensity of the stretch itself, which is very, very important. And then we also talked about it kinesthetically, comparing the kinetic chain to the microstretching chain. As you guys remember, what we mentioned about that was that with the kinetic chain, if we go from the ground up, it's calves, hamstrings, glutes, but with a microstretching chain, we said the difference is that we're looking at the origin and insertion of the muscles and basically trying to put together the proper stretching protocol or sequence that actually will deal with the issue at hand. But one thing that's very important with proprioception is actually it's been studied for almost 200 or 300 years. In Germany in the 1800s, they basically said proprioception had to do always with the mind and nothing with the body. It's only in the 1833, actually, there was a guy named Charles Bell from England that actually was a person that coined the term proprioception probably. But I call proprioception perception. So if you look carefully, if we look at this diagram here, there are no lines actually joining the three circles, but you automatically will picture the triangle in there. So you're getting a sense of what your environment is telling you visually in this sense, but the body does it kinesthetically. So when we think about proprioception, we definitely think about the 5 senses in the body and how they interact with one another. As you can see, hearing, sight, taste, smell, and touch. But there's also a 6th sense. And I don't mean this sense, which is ESP, which is how microstretching fits into the realm of the zodiac sign, as we were alluding to earlier. Extrasensory perception. What?
I thought the 6th sense was Twitter.
Yeah, exactly. You know, a long time ago, I often said if I actually had a crystal ball reading when I first started this about 30 years ago, and somebody said to me I would be involved with stretching, I probably would have shot them and asked for my money back. I didn't believe in stretching back then, honestly, and I'm being quite honest with everything. And it's kind of funny how it all developed from that car accident back in 1980, when was it? 1989. January 25th, the day before my birthday, 1989 is what started all this microstretching stuff. But the 6th sense in sports, and the one that's very, very important for us, is the sense of proprioception. So, I mean, this is what Charles Bell mentioned, and I'll read it because Joy is driving. So what Charles Bell said is, we are sensitive of the most minute changes of muscular exertion by which we know the position of the body and limbs when there is no other means or knowledge open to us. So and what I've actually coined in 1995 when I was approached, I used to be the head coach of the Vancouver Rowing Club, and Silken Laumann, who was our singles athlete and won the world championships in singles, she asked me about my perception of training and all this. And I said to her, to me, training is absence of thought. Now, what do I mean by that? And then further on, it becomes essence of feeling. So every time we start an activity, we think about our activities, how we place our bodies, how we lift, how we twist, running up and down the track, jumping up and down the track. These are thought processes. So in essence, proprioception starts consciously in our mind, and then it becomes subconscious and it becomes something automatic. And this is very, very important with regards to when we're looking at the body and how we're treating the body. The one essence that we as therapists and coaches and athletes have got to realize is that the person themselves, when they're actually injured, they do have a conscious recollection of the injury, but as they progress through, how do you say, post-injury and all this, they've lost some of that proprioception in the sense that they're not, the neural system has been affected in a way and a manner where they're not processing their environment properly. Now, interestingly enough, when I was researching the proprioception, I always thought that proprioception is something that is only measured in the joints. But oddly enough, it's not just the joints, it's the muscles themselves. And so we're going to get into the tissues of proprioception. So we'll discuss this as we progress. So when we say muscle sense, what other words do we refer to? And kinesthesis, kinesthesia. So kinesthesis is the Greek word kinesis, which means movement, and aesthesis, which is feeling of movement. So this is where the word kinesthetics or kinesthesia comes from. But proprioception is the one word that we use a lot in therapy and in sports. And I mean, even though there is a therapeutic technique, stretching technique, that basically focuses on proprioception. It's called Pnf, Proprioceptive Neuromuscular Facilitation. It is the technique, and I'm sure a lot of you guys have been exposed to it, where you basically have a person, so it's an active technique. So the athlete is down on the ground and you have, let's say they're stretching their glutes, or actually in the NBA, you see a lot of these 6'7" monsters, and you've got a therapist who's 5'5" and he's grabbing the knee, locking the knee, pushing the lower leg towards the knee, and then he's trying to stretch the hamstrings. So that, and then you can see the athlete push against them for about 8 to 10 seconds of isometric contraction, and then the limb will move to another position. Well, basically what you're doing is you're using the proprioceptive tissues to work. You're actually engaging them. So these are, to continue on with proprioceptive neuromuscular facilitation, I am not a big proponent of it. From an acute point of view, if you want to get your athlete back on the field or back throwing or putting or how do you say, jumping and all this, it's got its place in the realm of performance. However, it is an acute response. It won't last, but you'll get your athlete out there quickly. But all you're doing is basically tricking the body to give it more range of motion. So this is what proprioceptive neuromuscular facilitation means. And the origin of it, which I found very, very interesting, when I gave a talk at the FA Medical Conference in 2005 at what's the National Training Center in Shropshire, Lilleshall. Okay, I went to Lilleshall and I gave a conference talk there, and there was 130 therapists in there. And back then in 2005, proprioceptive neuromuscular facilitation was becoming the big in thing in the UK. I mean, we had basically done that route in North America by about 2000, 2001. So everybody, and I said, who believes in this? And everybody put up their hands and they use it. And I said, let me be the first to say that it's not cracked up to be what it's supposed to be. The origin of Pnf stretching was developed by Dr. Stanley Kabat and Mary Voss in the 1950s to deal with child onset paralysis. So you got to think, you've got a technique that they're actually using on compromised individuals that can't develop enough force or generate enough force in their muscles. And then you're introducing it into a healthy population, which is athletes. And to me, those 8 to 10 seconds of intense isometric contraction, I think, can cause inflammation and damage. That's just my personal bias. So anyways, so here we go. If you see the box, which is yellowed out, those are your proprioceptive tissues. So we've mentioned them as the muscle spindles and the Golgi tendon organs. And these are found throughout the body. Here's an interesting thing about these proprioceptive tissues or muscle spindles. There's a reason why you're able to put your finger into your pocket and be able to feel a pound or a quarter or a dime and distinguish it. But you couldn't do the same if you were to actually put you tried to use your calf muscle to try to discern whether you've got a dime, a quarter, or even a penny. The reason is, for 1 gram of tissue in your fingertips, there's 120 muscle spindles. For the same area in your calf, there's only 5. So that's very, very interesting. So you are actually able to sense more with your fingertips. And, you know, not to mention that there's a lot of neural endings that end up in the fingers themselves. So now with these tissues here, the diagram at the top here, Joy, there's a schematic diagram that basically shows the muscles. And actually, Richie's gonna, well, this is being recorded, so you'll see it. And at the top is your muscle spindle. Now, interestingly enough, the muscle spindle lies parallel to the muscle fibers. So the muscle fibers in this case are called extrafusal and outside of the cavity. And then you have the muscle spindles, which are intrafusal. So this ridged area here that you see here are the intrafusal fibers. These little dots here, guys, are your motor end units. So this is your nerve here. Okay, this is your nuclear sac right here, this sac here, and these are the motor end units. And interestingly enough, the more complex or the more, how do you say, not complex, but the more dexterity, let's call it complex, the movement, like hand movements to grab something, you have more motor units per muscle, okay? Less, so acute or finite, that's the word I'm looking for, compared to gross. So if it's gross, big, then you don't have as many motor units per muscle fiber. In fact, with the finite movements, you actually have 1 motor unit per muscle fiber, or units of muscle fiber, which is very, very interesting. And this is connected to the spinal cord, which then goes up to the brain. But interestingly enough, the beauty about these proprioceptive tissues is you actually will respond to any stimulus prior to you consciously knowing about it. So this is why the German thought of it's all in your brain was disputed. What happened was that we've realized that, for instance, if you put your hand on a hot element, before you even notice that your skin is burning, you have moved your hand. So it's a feedback loop within the periphery, and then it goes up into the central nervous system. So the other thing is right here between the tendon and the muscle is the Golgi tendon organ. And interestingly enough, the Golgi tendon organ, which is down here on your lower left side, it is basically, it senses tension. So the muscle spindle itself senses stretching. The Golgi tendon senses tension. So let's take it back to microstretching. Why are stretches held for about 60 seconds as opposed to anything greater than that? Okay, we know that it takes about 30 seconds to move from the middle of the muscle belly out towards the myotendon junction. So where the muscle and tendon meet, this area here, you actually will allow another 30 seconds. So basically, the minute itself is allowing us to get to the myotendon junction, which is the area of concern. As we've said before, muscle stretches 1.5 times its own length. I'm not really concerned about muscle from a therapeutic point of view. I'm only concerned about it when we have a bad contusion, you know, a bad Charlie horse, where muscle can actually develop what is known as myositis ossificans, which basically means that it is hardened and there's not a lot of pliancy in it. So, but my main concern from sports, my main concern with athletes and patients is the myotendon junction, because 90% of injuries, all injuries happen in that area there, mainly because the tension generated at the myotendon junction is of such where the tendon, which can handle a lot of force. Like for instance, as I mentioned before, tendon is so strong that it actually can avulse bone from bone. The other night, Richie, myself, and Mike Cimello, we were talking about avulsions at the ischial, ischial tuberosity. Not the ischial, the tibial tuberosity, where your patellar tendon attaches. And I have literally seen athletes that have come to me who've literally pulled bone away from bone, because when the tendon enters into the bone itself, it actually flares out like a fan or a turkey tail. And so it's for sure, we know that it's adhered there. So it can pull bone away from bone. Now, the interesting thing about the Golgi tendon organ, as I said, it's about sensing tension. So both proprioceptive tissues, whether they're the muscle spindles or the Golgi tendon organ, they work through the concept of tension. Now, if the stretch is held greater than a minute, the Golgi tendon organ, or the axonal nerve, which is the nerve that you see in the capsule itself, will start processing an increase in tension. Even if the tension is gentle, it will perceive it as tension. So the whole idea is that proprioceptive tissues, not only have they been designed to allow us to process our environment, but they are a fail-safe system to help us prevent us from creating more injury in our tissues. Okay? So now, what's so important about the proprioceptive tissues? Balance. One thing, which is very, very important. Structural integrity is another one. So this diagram here, I did this today, is just basically show you the importance about balance and the importance about having symmetry. This is another thing that happens when a person is injured. They become asymmetric, i.e. they will be compensating, they will be protecting one side over another side, which then starts this whole muscle synergy of protection. And as a therapist like Kelly and myself, what we look at is we're trying to give back a balance to the body, but we have to do it from a bilateral point of view. I've had a lot of patients say to me, well, why are you stretching my right side when I have injured my left side? Mainly because the right side now is getting involved for protection. The body is imbalanced. The beauty about stretching, and this is one thing that I've been developing over the years, is by placing a person in a certain position, and Tom Walsh has alluded to this as well, is that you will get a sense of how tight that person is by looking at how they're placing their body in those positions. As Richie, for himself, he's actually had a right hip replacement. Is it the right that you had first, Richie? Right. So Richie had his right. Now it's his left. So the issue was that after having the right done, he applied a lot more pressure on his left side. And now the interesting thing about sports is it's a compression, a dominant movement. We're always constantly applying pressure on our joints, shearing and tension and compression. But compression is the biggest one that we actually do. And this is the one that's causing a lot of tissue damage. Joint damage. And the sad thing about it is that a lot of these joints that have basically taken over the job of another joint or another part of the body, a lot of those surgeries can be prevented if the person is taught how to work early enough through proper stretching. I use stretching for everything. I'm not saying it's the panacea of all therapies, but it's the one thing that I've been able to deal with fibromyalgia, chronic fatigue, multiple sclerosis, rheumatoid arthritis, osteoarthritis. I use stretching. The fact is that there's a lot of compression, there's a lot of tension in the tissue itself, which is going to affect the joints, which is going to affect the muscle synergy. So if you describe proper stretching or use proper stretching to, for lack of a better metaphor, give the body the ability to breathe, you're going to help with pressure that's being imparted on the joints themselves. So the other thing is structural integrity. This is something that is determined by proprioception as well. How we actually get this kinesthetic feeling of keeping our bodies upright. I mean, how many of us, well, we grew up in an era where, you know, we were taught posture was very, very important. We need proper posture. Well, nowadays, because of the cell phone, the tablets, the head is constantly being brought forward and down. And, you know, where your eyes look, your body goes. Interestingly enough, I don't know in other parts of the world, but here in Canada, we have seen a big spike in therapy focused on the neck and shoulders. There's been a lot of people that have been complaining about headaches, migraine headaches, shoulder issues, and partially it has to do with their ability not to sense their body. And the other thing that happens too is that they're rolling their shoulders forward. As soon as you roll your shoulders forward, your neck basically tilts backwards, which then means the muscles in the neck get tighter and there's tension in there. Okay, so you have to release that. So structural integrity is very important. So the opposite to that is what you see with the diagram on your right, where the joints aren't, or the body, the muscles, they're not working in synergy. So there's mainly, it's a collapse. Okay, so what does this all mean? It means, as I was mentioning earlier on about Richie, it means that if the person has an injury on their, so we're looking at this person's hips. So your right is their left hip. They will automatically be putting pressure on their right hip, which is our left side as we're looking into this diagram. That basically means you're starting to wear down the joint. What first happens is bone spurs, you know, and bone spurs are an indication that the joint is starting to basically not only become arthritic, it's starting to die. Okay, so this is the one thing, and again, that's compressive force, compressive force. So you need to place the body in a position where you're trying to open up the joint capsule. And in this case, it's the femur. So we're gonna end off with Richie. I'll see if I can do this. And notice what Richie's doing is he's doing this exercise. Richie, you wanna explain this?
Yeah, this came from our athletic trainer, and he's pretty knowledgeable. He's worked with some Winter Olympic teams and does all our rehab for injuries, like knee replacements and other things. Not knee replacements, ACLs. But he gave me this, and I use it with the guys because you've got to really watch being in good position for me and them. But it basically is it's not stretching, it's not relaxation at all. It's very tough, but it's much more making everything fire properly in the hips. You line up the legs shoulder width apart. Here you can see feet forward, knees forward, quad parallel to the ground, which is tough. The kids in the process of doing it, they get too high. Doing it slowly, and it becomes a very, I mean, it's, you start working and shaking, and at first your balance isn't very good, but as you get better at it that day and over time, you get a little more control. You know, my view always is that balance is basically just muscles firing properly.
But you see what,
so,
sorry, Rich,
know,
but you see
anyway,
what Richie, but you see what Richie touched upon? Initially, there's a lot of thought that goes into this movement. That's proprioception. So it's conscious, because proprioception is the amalgamation of physiology and psychology. So in order for Richie to do this properly at the beginning, he probably had to watch how, if his legs were shoulder width apart, if his hips were square, and then the amount of tension that he's picking up. That tension that he's picking up are the proprioceptive tissues that are firing to keep him in that position, to keep him balanced. Eventually, you get to the stage where Richie is probably able to do this right now and not give us enough thought process to the situation of being able to do this exercise. Yeah. So yes, Richie?
The other thing about this, it's, and you know, for lack of better word, and this is what he said, and this is what you feel, it's the proprioception definitely, but you do think about getting in line. You make sure you glance, you know, to make sure you're in good position, your knees lined up, your hips aren't rising, and because once you get into this position with hips parallel, you really engage the glutes and everything else, and the rotating does the piriformis, all the other muscles, but it makes the muscles work things out. And at first you're not very coordinated, and it makes the muscles work it out, and you keep doing it, and they start getting better at it as you go, because they kind of figure out how to fire, how to balance. And that's what I like about it, because as Nico said it to the kids the other night, everything you do in running, cross country, track and field, everything you do, the hips are the center of everything. Mm-hmm. And that's where a lot of injuries either occur, wear and tear occurs, or because of imbalances there, injuries recur in the extremities. So, you know, this is something that's really helped me going, and until both hips are titanium, and everything will be good.
But you see, if you watch carefully, look at the knee, look at the legs, look how the body is processing the information as Richie is swinging to keep that balance. That's your proprioceptive tissue at work. Now, Richie's probably, huh?
Go ahead.
Richie's probably focusing on his rotation. Richie's probably focused on the rotation, but the body is automatically providing that balance for him while he's doing this. Look at the both legs, both limbs, and Richie's just focused on rotation.
But
so that's your proprioceptive tissue, huh?
The kids kind of rush through it and don't feel it. And then when they do it right, they're like, "Oh, okay," because you can start shaking. You feel things. You literally, while you're focusing on good position, you're feeling the muscles do it, which I think good for the kids too.
Yep, definitely.
I have a question right now, because it's kind of based on this. I was thinking of it a minute ago when you showed the Kinetic chain. A friend of mine who coaches mostly distance runners suggested this, and I've used handstands forever for pole vaulters, but he talked about lining up the system better by doing handstands and basic movements off that, where you have to, you stand up on your feet, you can get away with sloppy posture and poor balance.
Yeah,
because you're used to it. You get upside down, your center of mass is skewed, you've got other problems, your shoulders aren't strong. You really have to, and it makes some sense, and the same thing happens. I don't do them because I'm too darn old to do them, but the kids say, "Oh, I can feel my body trying to adjust and align." So we started doing that with the cross country kids too, to try to get that feeling. I mean, that kind of the same principle, I guess.
Here's something really simple that I use in the clinic a lot to get people to fire their hips properly is, Kelly, this is actually a little clue for you as well, is I get them to walk backwards. The moment they actually think that they have to walk backwards, they start thinking of how they're going to move their lower legs, their upper legs to accomplish that exercise.
Say it again, because you kind of paused.
I did? Hey, so far, okay.
Okay, you get internet problems again.
Running backwards is hard.
I'm not actually, yeah, it is, but Richie, I still think I'm on. So all I basically said is I'm getting them to walk backwards, not run backwards.
Okay.
And what I do is I basically get them to a position where, because like Richie touched upon it, if you actually go forward, you become sloppy, because it's something that you've been doing most of your life, or all of your life, actually, when you started walking. But getting a person to walk backwards will get them to focus on lifting the lower leg, swinging the knee backwards, planting the toes down into the ankles, and then repeat the exercise on the other side. Now, another thing that I've done with a lot of my athletes is I actually get them to walk backwards in a sand pit, because sand introduces another realm of imbalance, which is very, very important. So they're going to start firing their proprioceptive tissues, because as we touched upon last week, and I told you about that example with Michael Owen in 2006, I was working with Newcastle in 2005, and Dougie Wright, who is the physio there, he wouldn't let me touch Michael Owen, but month before the 2006 World Cup, I basically said to Paul Winsper, who was the S&C for Newcastle United, I said, I don't even have enough time to turn around Michael Owen's body. But I will tell you right now, he's going to suffer a major injury at the World Cup. And he did. He blew his knee out. Mainly because if you follow his history, he's had oodles and oodles of hamstring tears and strains. And he actually ended up having a knee surgery with Stedman out in is it Utah? Stedman, the Stedman Clinic. But the issue was his proprioception was off. So proprioception is giving you the ability to sense or know your environment. So what happened with him is he thought his leg was planted when he went to turn, but it wasn't. But then when he did turn, that's when it planted, and that's when he blew his knee out. So one of my biggest pet peeves that I have with orthopedics, surgeons and stuff is, when is the athlete cleared to go back on the field? And I'm telling you right now, one of the issues that has to be looked at from a therapist point of view, from a coaching point of view, is reestablishing proprioception, which is very, very important. Get them to do hops, like bunny hops, and you will notice that one foot's got more of a plantar flexion than another one. One foot is slightly ahead of the other one, and they think they're balanced. I think Richie was touching upon on Monday. Monday, he was telling me about athletes that thought they were symmetrical, Richie.
Yeah.
But when Richie went and, yeah, okay,
I'm just messing. That's me, actually.
That's so
I'm showing you what they were doing to us in those other presentations.
Oh, okay. So what it is it's interestingly enough, Kelly, when you actually, and you know this for sure, is when you get a patient and you try to correct them and say that this is square, they have this perplexed view that they thought that they always felt that they were square. So the proprioception was off again. And think about it. If the athlete doesn't have proper proprioception, will they ever maximally perform? I doubt it myself.
There's another, the proprioception is the result of all the senses.
Yep.
There's another, you change the environment, like you talked about using the sand. The reason I got my right hip replaced 12 years after it happened was in 2004, I slipped down a glacier, ran into the rocks. That's where I jammed my right leg in, but I also had a major head concussion, had to get life flighted off the mountain. And I still have no, because it was nerve damage, I have no inner ear function on my right side. So I had really bad vertigo and other things, and my balance was off. And I wasn't very good for a few weeks anyway, but even after I got better, and this woman helped me with some basic things there. And one of them was close your eyes, where you take away the major feedback, and walk forward. And then open up, you said, don't do it in the middle of the street. I have an empty driveway. So walk forward, do that. Then open your eyes, then turn around and walk back in, walk backward doing it. And then progress to walk forward, do a 360 and walk forward again. And, you're going way off to the left at first. You're not very good at it, but eventually you start to develop. And what it does, it literally teaches the brain what you've got to do and take over for the fact that the inner ear isn't going to give you any feedback on things. And so, and I'm sure I'm not the first person to do it, but shortly after, when we do some of our sprint drills, we just did basic form and walking drills and walking over really low hurdles. And then you tell them, shut your eyes. Or we do standing there and lift up the hip, get in A position, close your eyes. They do that and they start falling over literally because they don't have anything to balance them. So in a way, it forces them to have the muscles take over more role in proprioception. And just simple things like you're saying, walking backwards. We'll try walking forwards with eyes closed and walking backwards with eyes closed and see what happens to them. But it forces the muscles to then learn how to do it and take over without that key feedback.
And this is the one thing, athletes that have had a lot of injuries, whether they're repetitive strain injuries or injuries where they've, hey, there she is, where they've actually, suffered a tear and stuff like this, their proprioception is off, and they have to what's the best way? Neuroplasticity. I'm going to bring this concept up because this is the one thing that we've seen with stroke victims as well, is that they try to reestablish a neural connection in the brain in order for them to fire up their muscles. And this is where a lot of new therapy is going. There was a neurosurgeon a neurosurgeon who basically suffered a stroke, and she was able to reestablish different synapses in the brain. Well, your body's no different. So what you're trying to do is first of all, you're using your conscious mind, like you said, Richie, to focus on walking forwards with your eyes closed or walking backwards with your eyes closed to create those neural synapses in the periphery, so you're much more able to do those movements. And this is why there's a really good friend of mine. I don't know if you guys know John Kiley in Britain. Have you guys come across John Kiley? John Kiley's an Irish guy. He was involved with the Irish rugby team. He was involved with UK athletics for years. He was the head S&C. And his whole idea is when an athlete comes to him for recuperation and therapy, he just does a simple test where he gets them to step up on an 18-inch box. And that in itself gives you a quick indication of how off they are with regards to their balance and their muscle synergy. So, and his argument has always been, my argument is, when is the athlete cleared to train again or compete again? And I'm telling you, we put them back on the fields a lot faster than they should be. So, and then oddly enough, they get re-injured a lot faster than they should be. And that's because proprioception is affected.
And that gets to an important point Harry Mara made a week or two ago, and he always makes, and a lot of good coaches make this, and you all know this. The last thing that you should be doing when an athlete or a group of athletes is warming up and preparing is look at your phone or go somewhere else or talk. You ought to be watching them, because that's where you see more than in the workout. If they're all right in the warm up, the workout's going to be fine. If they're not all right, then it doesn't help watching them in the workout. Because you can see those things, and it doesn't take, a trained physical therapist or anything like that to do that. It's like you say, he can see there, you can see some of those things anyway. And the second thing was what Tom said a couple weeks ago when he was talking about, and it has to do with developing and keeping those synapses going. If you don't do a motion, or if you have a little difficulty doing the motion, you don't work on it, your brain's kind of like, okay, we don't need to keep doing that. Mm-hmm. If you keep doing it and develop the ability to do it right, but keep doing it, your synapses are going to say, okay, we got to keep that in our arsenal to keep doing. So it's like the move it or lose it theory there. And I think Tom was the one who was bringing that up a few weeks back. And that's the same thing. You got to. And that's one of my things I hate most, and it's still in our USATF curriculum, the muscle memory. It's the whole nervous system memory of motion. It doesn't just have to do with the muscle, but if you don't do anything with it and you don't develop it or continue to, that's why it drove me nuts, and it's still around today. You're injured. We try to tell the parents, educate the parents and the kids, if you have a problem, an aggravation, a slight strain, an issue with your ankle, an issue with your knee, don't just go to the pediatrician or have mom, Google a nifty, orthopedist that they heard about that somebody said an ultra marathoner uses, then your daughter's a sprinter, and go, because they might come back and say, oh, it's like, a very minor strain. Don't do anything for 6 weeks. No rehab even. And we're like, and the trainers can't touch her, and the other doctors don't want to do it. So we have our own, our trainers can get them with other doctors who are on their insurance who really know what's going on, because that's still what you get sometimes from athletic trainers, or put some ice on it and don't do anything for a week. Well, you're in worse shape than before you were injured, you know.
Well, mainly because when you start doing that, you're going to lose off the bat. You're going to lose 10% of your muscle mass, you know, and the ability to compete. But more importantly, again, it's your not muscle mass, but muscle function, not muscle mass, muscle function. Sorry, guys. But more importantly, you've got to use, as we touched upon earlier on, a gentle movement to be able to, as the tissue is being laid down, to align it in a proper fashion. And you're not going to do that by immobilizing. As I said earlier on, the reason why a lot of patients are after surgery the next day are up and moving is because the veterinary doctors noticed that a lot of animals, after they've had surgery, they basically a day later they're up there moving, and the incident of having pneumonia or developing pneumonia or developing fluid in the lungs is somewhat diminished immensely by the fact that they're moving again. So think about the body as the same way. Think of the muscle as the same way. You've got to be able to start moving it in ranges of motion that feel comfortable, but at the same time, you can't focus on the immobilization. And again, that's based on the intensity.
Well, my doctor, when I talked to him a week or so ago, because I'm going to get this other hip done, he goes, "You don't even stay overnight now. It's day surgery for a hip replacement." You know, and that when I did the first one, I got up that afternoon. I said, "I have to go to the bathroom." Nurse says, "Number one or number two?" I said, "Number one." You know, wheel yourself around, put your legs down, grab the walker, walk in there. If you need me, tell me. And I didn't need her. So, I mean, they have you walking immediately and doing it. And now it's, you don't even have to stay unless, you know, there's some issue. But I guess you got to pee before you go home. But I had a question back when you were talking about Golgi tendon apparatus. When we first started doing sort of the principle of gentle stretching, and maybe even before I'd even read your stuff, you know, it didn't make any sense to me, you know, this intense stretching, locking leg that caused this pain. And I guarantee if you had an athlete who was, you know, decent shape, but not necessarily training hard, and you went through intense static stretching to the point of pain for 30 minutes, that the next day they'd be sore, especially for one thing, it wouldn't stretch anything. It's the tug where you're talking about, because everything would contract. They'd be sore at the point of connection between the soft tissue and the muscle.
Well, I mean, if you think about it, aggressive stretching to the point of pain and discomfort will give you DOMS-like effects, delayed onset muscle soreness. It's the exact same thing.
But it also is the Golgi tendon that when you try to stretch too hard, it immediately causes that whole muscle to contract.
It's exactly what it does.
And so all the strain most of the strain goes to the part between the muscle and connective tissue, which is the most dangerous place.
Yeah, the myotendon junction. So the thing is, the tissues have been designed to prevent the connective tissues, the musculoskeletal tissue, from causing a lot of damage. So when you jump and you land, your muscle spindles are activated to prevent the muscle from continuing to elongate. Okay. And at the same time, the tension picked up by the Golgi tendon organ keeps the system within its controlled environment, its physiologically controlled environment. If those two tissues aren't working properly, you're likely more likely to tear or strain, which is what happens sometimes. And think about it, if an athlete's had a lot of injuries, they're more likely to re-injure themselves because those proprioceptive tissues aren't functioning properly. You have to retrain them, you know, which is very, very important. And part of that retraining is when we go back to consciousness. You got to be able to consciously put your initially your body in that proper position to feel and get that stimulus to your brain, knowing that, yes, I can feel my leg being brought forward. And these are baby steps, but what's more important is you will be able to keep your athlete on the field with less injuries or recurrent injuries if you take that time to develop the proprioceptive tissues. It's intention. So you have to have that sense of the intent of being able to feel what your tissues are doing properly after an injury. Any questions? Kelly.
Anybody can unmute themselves if you want.
Just everybody unmute themselves.
Yeah, I think that's so important to recognise, because I think a lot of physios and other people, they've got a big emphasis on getting them back as soon as possible because there's a lot of pressure. But yeah, I totally agree with you. Yeah.
You know, the thing is,
I suppose that's particularly true in with professional athletes, isn't it?
I was just going to say,
especially when they're on contract, and you know they could be on the last season, and they just want to get them back out there because they want them to compete. They don't care what happens after that.
well, look what happened to Kevin Durant.
Yeah,
Kevin Durant blew his Achilles tendon. You know, he wasn't managed properly.
The same thing happens at NCAA level because the coaches and the teams want to win, and the same thing happens at high school level because the coaches want to win. It's not always the best interest of the athlete.
And here's an interesting thing about this whole topic that we're touching upon: the use of NSAIDs. I don't know how prevalent it is in the UK, but here in professional sports, non-steroidal anti-inflammatory drugs like Aleve or ibuprofen are used like cotton candy.
Yep.
Yeah.
And then the issue then becomes twofold. One is you're masking the pain, which then means you could be creating more issues later on. But more importantly, I don't know if you guys know, but the statistics are out that show that people that use excessive amounts of Aleve, which is a naproxen based, can cause liver damage. And ibuprofen affects the kidneys. And one thing that was used when I was working in the NBA, they used a thing called dimethyl sulfuroxide, DMSO. And DMSO, Richie's nodding his head. DMSO, if you look up the biohazards of DMSO, it's actually on the chemical hazards list. And this was used in the NBA like Jergens lotion. Mm-hmm. And the problem with You're
doing, Malcolm.
Speak up, Malcolm, please.
Malcolm lost his fortune when they.
What's the date of that book? What's the date of that book? 80s?
You
gotta unmute yourself, Malcolm.
Malcolm, you're muted.
Just keep everybody unmuted, Richie.
I can't. It says asked him. Everybody is unmuted. He's muted.
Oh.
You got to unmute yourself.
Unmute yourself, Malcolm.
Still mute.
There he is.
He is now.
Yeah.
Most people don't want to listen, so this is a thrill for me.
See what I'm talking about, Kelly?
1981.
Yeah, 81.
So I will tell you a story, Nikos, and this is just you and me. Nobody else is hearing this.
Yeah.
We were made aware of DMSOs. So this is when I was first at Florida State, and its power to absorb.
Yep, exactly.
And no, I don't need to name the athlete. It was used on the Achilles tendon, and I think with crushed aspirin to help with Achilles tendon, and it was very successful.
Mm-hmm.
My other example, and I know he's not online, was a gentleman by the name of Peter Thompson, who I think a lot of people are aware of, being with him in Eugene one time, being at a party. and finding out later that someone had put it on the handrail on the stairs with a little extra something. And so a lot of people were wandering around high as kites, unaware as how it happened. So, but this was used on horses, right, originally?
Wondering who'd put garlic in their beer.
Yeah, and interestingly enough, DMSO actually is a byproduct of the pulp mill industry.
Yeah.
And
And was it banned for the horses or not?
I think it's banned now for horses because
Yeah.
the interesting thing about DMSO and why it got used a lot is it's not that it itself is the realm or the thing of therapy. It's the fact that it is a potent, it just opens up all the layers from the skin to the muscle.
Right.
And it just bypasses all those membranes, because one of the biggest problems I see in the industry with regards to Voltaren or A535, all it is just the topical irritation of the skin, but it doesn't get down to the muscle. It's not an anti-inflammatory, but they market it in a way where they make you think, oh, if I take Voltaren, next thing you know, I'm going to be dancing up a storm. But you're not, because the issue is it doesn't have the driving agents, those are the words I'm looking at, the driving agent to take it topically to the muscle. And DMSO was used a lot as a way to not inject, to use steroids as a way of driving steroids into the body.
Yeah.
Also, remember Tiger Balm. Some people still use it. I know it's more topical, but I know Christian Taylor, he must have a sponsorship of it too, because he puts them on right before he jumps, and everybody's like, oh, what's he doing?
It smells so nice.
I know.
Forget about what's that thing called? Axe? Is it Axe, that thing that men wear?
Yeah.
Oh, yeah.
Oh,
it smells like Tiger Balm.
I've always loved it. I put it on my temples when I got a sinus.
Yeah.
Under my nose is the menthol and stuff.
Yeah, the menthol.
It's the menthol, yeah.
It's very topical, but it still helps open my head up. But
no, but this is the thing with DMSO, and I was watching a therapist apply DMSO to the athletes, and the therapist himself was wearing 3 or 4 layers of surgical gloves.
Whoa.
Yeah.
So what's that telling you? What's that telling you?
My
Dad
got a hold of that from a friend who got it from a vet because he had such bad arthritis in his toes. They were like curling over like that. And he put like a drop on the toe and he'd feel better for days. And
yeah, it's true. But it's a driving agent.
Droplet deal. Yeah.
It's a driving agent.
I think we had to get ours from, at the time, it was legal in Eugene. I think that's where we ended up getting ours from, but it wasn't legal in Florida at the time.
It's illegal in Canada.
Uh-huh.
You can't get it in
A
Canada.
lot of it thought it was legal in Eugene, but it hasn't actually been legal. Okay, let's not go there until the investigation's finished.
Mm-hmm. True.
You can get anything anywhere.
But any other questions?
Yes.
Yes.
I have
All
a
right.
question. First, bye, Jimson.
Bye, Jim.
Hi, Jameson.
Yeah, good seeing you.
See you, Jimson. Huh?
I don't know if you talked about this last week about ice, because I know from some friends in the UK that are anti-ice. The whole thought about this, and I kind of understand both sides, is because if someone gets hurt, the whole rice thing that we learned a long time ago, and sports
Mercola.
medicine. Yes, rest, ice, compression, elevation. And then Kelly, if you're here, I want to hear.
I was just going to say Kelly's going to answer.
Kelly,
this one.
because you're in the UK. But you think, okay, so your body is saying, something's hurt. So your body works and helps yourself heal. So all the blood comes to the area, there's the swollen, and you kind of, it's healing. Your body's trying to heal itself. But then when you're like, oh, well, let's put ice on it. And then, whoa, all the blood goes away. And so there's, one, because it feels like, it feels better. It's cool because it's hot. What do you guys like to do? What's
Okay,
your
Kelly,
new
it's
thinking?
it's your thing, Kelly.
Yeah, it's a really good talking point, this. So it is taught at schools, it's taught in massage qualifications, it's taught everywhere, that you rise and, you know, to not put heat on it, but it's slowly kind of getting around, and I mean, I'm not too clued up on the research, but personally, I would definitely put heat on to kind of accelerate that blood flow to the area, and I would really refrain from, if it's not painful and if you can deal with it, then yeah, putting that heat on. But if it is painful, then I think ice is the right thing to put on, if you can't deal with it. Yeah, so you accelerate that blood flow and all those healing properties there. But like I say, it's very, not many people are aware of that, particularly athletes. They love putting ice on themselves.
Yeah. Well, and I'll chime in because we have this all the time, because two of our athletic trainers, put some ice on it. And then the other one is like, no, you really don't want to ice it. You want to let the natural processes happen.
Yeah.
Tomorrow, if it's not too bad, we may start contrast, ice and heat.
Yeah, contrast.
Flushing it out. But right then, it's kind of like post-training. Right then, the other thing it does too is if you jump into an ice bath, it cuts off your hormonal response of what you're trying to do. I mean, it seems to change everything. But the other thing about the bag of ice packed on the ankle, use that as a simple example. That happens a lot.
Yeah.
Well, even if it were to do something really beneficial, it's almost more topical than anyway. It's not going to really ice down very deep, like Nikos was saying about, you know, things like Voltaren and stuff, unless you immerse it completely in a bath for the ankle. But even then, it seems, and I've had this talk with, you know, John Turek every year at the decathlon, heptathlon in Dallas. Oh, the first day, send your athletes over to ice bath. Oh no, it's all right. And I have them leave, go and get something to eat after they do a good active warm down. Go and get something to eat, and then go back to the hotel, and it's 3 hours later, and go sit in the pool, walk around the pool, gently move in the pool, a little buoyancy, make cool off. It's usually 100 degrees there in the, you know, for competition. But the last thing I want them to do is just shut down their system completely. You know, after the second day, if they want to, great, but I don't even encourage it then. But that's, you know, and I talked with Nikos about this at one of these. You know, and one of our other coaches immediately wants them to get in there. But, you know, the way we've used it is, especially like cross-country guys, or morning hard workout, then the next day they do another workout in the morning. They can come after school and get an ice bath if they want, and then that night go home and microstretch, or, you know, contrast kind of thing. It's hard. We don't have the facilities for a lot of that, but they can at least ice bath. But it's a day later when they've already done another moving around in recovery from the day before too.
The most important thing is to keep circulation going. Like, I mean, for instance, lactic acid dissipates from the body within 30 to 60 minutes of cessation of activity. But, you know, contrast baths, what they're doing is, as we've talked about before, it's your veins. Your veins are not very muscular. So the way the blood goes back to the heart is the vein has a valve, and the valve's like this. So it pushes open and then it shuts. So it prevents the blood from coming. It's the same type of valves as you have in your heart, your tricuspid valves, your bicuspid valves. It goes from the right atrium to from the right atrium to the right ventricle, and then into the lungs, and then the left atrium to the left ventricle, and now towards the rest of the body. But there are valves there. So your veins are the same thing. They have these valves that open up and close. But when you're doing a contrast, and the way that works is through muscle contraction. So when you're doing a contrast bath, all you're doing is you're helping facilitate the ability to squeeze. It's what you're doing is you're just squeezing the blood up towards the heart again, which is very important. Now, the issue with ice, and Kelly touched upon it as well, is the thing is the inflammatory system has been designed to basically deal with an injury. When you ice it, you are in essence not preventing it, but you're sort of slowing down its ability to do what it needs to do. I personally, I've used heat as opposed to cold, mainly because I'm trying to create more circulation in that area. The way the body responds to inflammation is because the vascular bed in that area has been affected by the injury. So in order for your body to be made aware of an injury, your circulation, so the blood vessels themselves, they have what are known as epithelial cells. And these epithelial cells are open to shearing stress. So in order for those cells to remain healthy, blood moves through them in a shearing fashion. If that is affected and it becomes eddies, that's when you start developing atherosclerosis in that area. That's when you develop plaque, because the shearing stress is no longer in there and the epithelial cells begin to die. Well, it's the same thing that happens in an injury. So if I've damaged my blood vessel here and it's collapsed, the epithelial cells are the first line of information that says we've got an injury here, and it sends the signal to the rest of the body that says you need to bring in the neutrophils, you need to bring in the white blood cells to start the whole process. If you actually introduce ice in that area, you are somewhat or decreasing its capacity to send that signal to the rest of the body and create the inflammatory response, which is much needed. Now, having said that, athletes have a mind of their own. And I bet my bottom dollar, like if you talk to Jess Ennis during 2012, she would finish her training and she would immerse her whole body in a bucket of ice because she thinks that this is what she needs to feel better. So the question then becomes, Joy, if an athlete actually perceives this as something that helps him or her feel better, who am I to say as a coach and a therapist, that's wrong, you shouldn't be doing that? Because if you're doing that, then what you're doing to the athlete is you're giving them mixed messages, you know. But I'm of the belief that, you know, I like heat myself.
I'll tell you one thing that's going to happen now when we go back, there will be no more ice baths allowed at school for a while, even if we're doing, you know, even if we're back on course. Right. Just the whole sheer logistical thing of even one person that having it's not going to happen. But to piggyback on what Kelly said too, one time that trainer I'm talking about, I called him from New Hampshire about 5 years ago in the summer because our team was up there, and this kid had an issue all summer with a hip bugging him, and he wasn't really even running with us. We got there and he kind of stumbled and fell and started screaming. The kids got me, and Dad and I are trying to deal with him and figure out where we drive him to. We're 30 miles from the nearest, you know, emergency care center in the middle of nowhere. And I called this trainer and he's like, well, what are you doing? I said, well, right now I got ice on. And he goes, well, that ice ain't gonna do anything. I was like, he was cramping up and screaming. And so like Kelly said, it's a pain reduction thing. I mean, he was in such pain, and I thought maybe he strained his groin so badly it tightened up. He goes for an x-ray at this regional center, and then they send him to Dartmouth Hospital. The neck of his femur popped in half.
No way.
There was some pre-existing thing, and I saw that, and he goes, whoa, this is why he's in pain. I was like, and I went with him, and he had 5 a.m. He had surgery. That was how the parents flew up, and that was purely for pain. It wasn't going to solve any problem. No, but I'm thinking,
analgesic.
Just a torn muscle that's making him cramp up. But no, it was something bad.
You want to laugh? I'm actually chief science officer for a mushroom company.
Are these magic mushrooms or regular mushrooms?
You got it. You got it.
So you have to do the experimentation.
And one of my, you guys might appreciate this or may not, but one thing is we know that we're also looking at either psychedelics. We're looking at we're looking at ayahuasca. We're looking at LSD, and we're looking at mescaline. Now, why I bring this up is...
For 30 years, Nico, yeah?
What?
You know, I've been a cop for 30 years.
Yeah, I know.
The emerging mushrooms. I'll just
I
take a
know.
little bit of that if that's okay.
I'm very, very careful with how I'm going to choose my words. But actually, what we're starting to see with research is how, for instance, psilocybin, which is the chemical in magic mushrooms, Alan, there was a study done out in Johns Hopkins University with a guy named R.R. Griffiths, who looked at patients that actually had terminal cancer and very, very depressed, as you can see why. And what they did was they did one dose of psilocybin with a therapy session, and it actually turned their depression. It actually alleviated their depression for up to 6 months. So what it's doing is it's almost like resetting the brain. Now, everybody is focused on the use of psychedelics for anti-inflammatory for brains, because your brain has serotonin. See, the way the brain works is you've got dopamine and serotonin. Dopamine is what the beautiful iPhone, Samsung love it, because every time you're looking at your phone, even though you have no reason to look at your phone, it's because it's a dopamine response. So dopamine is a chemical that makes you dependent. So it's an addictive addictive chemical. And this is why drugs like, how do you say, what do you call those? Not barbiturates, morphine, those types of drugs, they create an addiction. Opioids, thank you. They create that addiction. Interestingly enough, the serotonergic drugs like LSD, mescaline, psilocybin, MDMA, there is no addiction. It's because it's working through serotonin. What these drugs do is they become what are known as serotonin agonists. So they're preventing, here's the interesting thing, serotonin is an inflammatory molecule. It causes inflammation in the body, in the brain. So everybody's fixated on what it's doing on the brain, but I'm doing research where I'd like to see if, this is where I'm going to get arrested by Alan right now, where we can use psychedelics as the fourth level of anti-inflammatories for the body. We have NSAIDs, which is what we've talked about. Then we have, the other thing is biologics, which basically they're put into the body as they're, for lack of a better phrase, they're like sponges. So they'll go in there and they'll absorb all the dead cells and the inflammatory responses, or perpetuate the inflammatory response by removing all the dead cells. There's the third one that fails me. And then I'm thinking the psychedelic drugs, because there have been studies that have shown that it actually helps with rheumatoid arthritis. So this is where we're trying to move into the realm. Now, having said that, I'm also researching CBD oil, which is very, very important, or CBD, because CBD works through what is known as your endocannabinoid system. And this is the system of homeostasis. So your endocannabinoid system has been designed to process the environment and allow the body to respond to the environment. So CBD, and oddly enough, CBD is actually legal by WADA standards as long as it doesn't have any THC in it. So by THC, if it actually has 0.1% THC in the CBD compound, then it's deemed illegal. So but anti-inflammation. And this is the thing we've touched upon from the time we first started this talk a long time ago, is about dealing with inflammation and creating the scenario to help the body recover by dealing with inflammation. You know.
Hey, do you use Venmo?
Which one?
Venmo or any of those payment things there? Because I'm gonna
Venmo.
have you. It's one of those payment services. I'm gonna have you just dump a bunch into my account so I don't send this to the provincial prosecutor in Ottawa. I've got this on recording. Remember?
Hey, interestingly enough,
too.
see Kelly. Kelly's
Send down
thinking
a
like,
case
what
of
the?
Lapap.
Kelly's like, what the heck are these guys
He's
talking
missing
about?
the visuals.
You know.
It is very entertaining.
This is it. It is. We enjoy talking.
Could I just go back to ice for a second, Nikos?
Yeah, sure.
It's
I'm
just,
glad you piped in.
I just not talking about the drug, Alan. What Joy was saying about the icing thing, it's just there's something that you might want to think about is the inflammatory response you get on an injury. The inflammatory response might not actually be ideal in certain individuals. So you might get someone who has a healthy inflammatory response, and then you don't want to interfere with that, you don't want to ice it, but then you might get someone who actually over-responds, and you get a kind of pooling effect. And then what that happens is you might actually want to interfere with that process so that you get venous return. And you'll know that if you really get involved with pain management with your athletes and get them to pay attention to how long it takes them to recover from their injuries. Another thing you might want to think about with the whole icing thing, and this applies more to the contrast stuff, is if you've got someone who they're going to play in an event maybe in 72 hours or 48 hours, and you actually might be able to get them to play not by doing things naturally, but by doing an artificially accelerated type of healing, which might not be ideal, but it means they're there and they're like your marquee player. That's like another thing you want to consider. So although it's totally agree with what everyone's saying, it's not really natural and it's interfering with the inflammatory response. Sometimes you might want to make that call and the athlete might want to. And the other thing is with neurological pain, when you get something like, you upset a disc and you get like a cramping sensation and then that's irritating the discs, if you put heat on that, it will actually make it worse. Whereas if you put ice on it, it will actually calm it down. And in a situation like that, it's not really so much the blood flow that's an issue. It's just there's an overcompensatory spasm to try and protect you and stop you from moving. And it usually causes more pain than is necessary. So I've actually found in situations like that, although it's not really en vogue at the moment, icing is actually a lot better than heat, and heat will actually aggravate it. Heat will actually make it worse.
Well, I'm glad you piped in.
There was somebody one time who was saying the ideal, logistically, you can't do this, but the ideal would be to gently heat the belly of the muscle and ice the tendons and ligaments at the same time, which of course you can't do, but that's sort of principle wise.
But Tom was referring to a disc injury with regards to using so basically what you're doing then by putting ice near the disc, you're actually somewhat lessening the neural response, correct, Tom?
I think that's the theory. And the heat actually excites the neural response, and it's already overexcited, and it just becomes more painful.
You're kind of numbing the nerve.
Numbing the nerve. Yeah,
exactly. Oh, and just also something for Richie, actually. Yeah. You know that movement complex you were doing with the lunge and the rotation?
Yeah.
Check out the Gray Institute. They do something called 3D maps. I don't know if you've heard of it, but it's the same sort of thing, but they also have like frontal plane and sagittal plane derivatives where you're using GRAY. It's called 3D maps. They're really like close guarded about their stuff, so you might not be able to find the movements. So if you can't find them, I can send them to you. But it's basically the same thing. You're using your eyes and your hands as the drivers to move the hips in all three planes of motion. And so if you're trying to wake up proprioceptors, it's probably like, it would just give you more options to do what you're doing when you get bored of that one.
Which is what we said a long time ago, where your eyes look, your body follows. It's kind of interesting how we think that way or move that way. in essence.
I apologize, but I got to get going and
Yeah, I mean, all of us too.
and then,
So when we first started this, Richie, I thought thanks, Tom, for that. And show yourself next time, even though it's 7 hours ahead in Berlin.
You don't want to see me right now, trust me.
Oh, I mean, you get to see this old codger.
Your hair can't be any longer than mine, Tom.
Hey, I'm going in for a haircut soon, anyways.
Get an estimate first.
What?
Get an estimate first.
Yeah, you don't need one.
There he is. That's better. That's better. Now we get to see the face with the name.
Fleeting appearance.
When we first started this, and Richie set up like an hour and a bit, I thought, Richie, an hour and a bit? Are you crazy, man? Half an hour at the most. But anyhow, again, what's next week's topic? Anybody want to pipe in and do something, or
Can I, Nikos? Can I just say, Rich, going back to something you said a little while ago, and something I've experienced personally, I've had 2 left patellar tendon ruptures.
Mm-hmm.
The first one was in 2008, and the reattachment surgery, they use suture anchors. Okay, and I had this impression that the tendon was going to grow back and okay, but cut a long story short, it took me, the rehab was through like a hospital physio. It wasn't a sort of the physio I would use, but it was
the NHS physio.
Yeah, but to be fair, this person, and she was really good. She was very, very good. And I used a bit of my own knowledge, and it took me about, I say, 18 months to get back to where I could get what I'd say maximal lifts in the gym.
Right.
18 months. Then 9 years later, it happened again. That was in 2017. And I thought that would be it. Done, gone. But the first time when they repaired it, they didn't use a cast. They used like a wraparound sort of
sleeve,
Velcro sort of with a hinge adjustment.
Okay.
That's what
like a brace.
Yeah, it was a brace, but it had an adjustable hinge.
Okay.
And some of the therapy was, I forget the name of the machine. They put my leg in this machine that just basically flexes it and straightens it.
So let me ask you before you continue. Was that machine the machine that was gentle movement, flexion, and then into extension?
Yes.
And it took like 45 seconds one way, 45 seconds another way?
Yeah, and then they start increasing it when they get a bit more excited about how much more movement I got, and then the pain goes up. Okay. So fast forward to 9 years, and I try to get back to running, because that's what I was doing. I could not put the power down on that left leg. I just didn't have the confidence.
Right.
That's when I started throwing. And all of the drills I use for throwing, if you think about it, it's basically it's really increasing. A lot of it was centered on core strength and stability, and also stability around the knee.
Right.
I could end a year later. I could run. So I could not run 2009, but I could do it in 2010 when I was throwing. Okay, so 9 years after that, it happens again, probably because I was training like a lunatic, because you tend to think you're still young when you're 50 and you're not 55. But this time, they used sutures, no suture anchors, a neoprene synthetic sort of ligament to wrap around the repair, and just put it in a straight cast. And I refused any pain-killing drugs, because I just thought I knew the pain would last 2 weeks, so I just refused it all. I didn't want any painkillers, and I recovered in about 6 months. I was able to do some throwing after 6 months.
Wow.
So the point of me saying that is, how would you, I mean, it's a little bit perhaps an unfair question. how would you have rehabbed that? Looking at that, the original injury, how would you have rehabbed that?
As soon as actually the surgeon, as soon as it was surgically repaired,
Yeah.
I would actually start focusing on the external rotators of the hip. So the piriformis muscle, the superior inferior gemelli, the internal external obturator, and the quadriceps femoris. No, not the quadriceps femoris. Obturator. It'll come to me.
Yeah.
And a lot of my focus would be on working the IT band, the external rotators, the groin area. I wouldn't, and then I would actually start doing gentle movement with the lower limb to try to give mobility in that limb that was injured. And believe it or not, I would even focus on the mid back, because all of those muscles are getting involved, oddly enough, proprioceptively, to protect. But the whole key as to why I would start therapy right after surgery, and I know they would never do that, which is ridiculous. So they would probably have you come to me a week later, is to allow the scar tissue as it's being laid down to lay down in a gentle fashion. So the whole idea with regards to that machine that they put you in, which was in flexion, extension, they should have kept it gentle. But the fact that they started cranking it and causing pain, so maybe they were trying to get you to push against it, or so their whole focus was on trying to increase the strength there. What they were doing then is they were introducing inflammation in the area that was not needing the inflammation at that particular moment in time. Plus, if it was your right knee, then I would then focus on the left side as well. And I would work both sides together at the same time. And I would see you only twice a week, and then I'd give you homework to do. So it seems like it failed because you may have developed scar tissue in that area. Like, for instance, I've worked with a lot with martial arts, Muay Thai, kickboxers, and these guys can do the splits.
Yeah.
But as soon as they're injured and they don't continue that form of stretching that they're used to, they contract. They lose a lot of range of motion. And that range of motion was created because of the scar tissue that was building up.
Yeah.
But that's how I would have,
My recollection was, Peter, and obviously it happened to you, right, that we thought that scar tissue from the previous occasion had been a culprit the second time around, right?
Yeah, very possibly. I mean, I also, like I say, my kind of training loads were sort of near maximal. So for quite a long time, for most of those, for 8 years, and
but once the scar tissue,
when the injury occurred again, the X-ray showed that it was a kind of a neat break, and that all the screws came out.